So it's Mari McInerney from Croaky, and we're at the APNA Primary Healthcare Nurses Conference in Queensland. It's the end of day one, so a little bit vague. And I'm here with Gibson from Ballarat, who has presented at a couple of sessions today about a very innovative nurse clinic, a nurse-led practice, with dementia. Can you, Carolyn, thanks very much for doing this at the end of the day, and can you tell me a little bit about the project?
Okay, so I'm passionate about people living with dementia having a voice in their own care, and so when I'm working in general practice as a practice nurse, I managed to get some funding in order to try and train up our nurses to deliver better primary care, and that was really just through some education and giving them some resources. And then I got a grant from APNA, one of the nurse-led clinics, so I was able to develop up a model of care to help support people deliver good dementia care, so how to ask the right questions and then how to provide some support. It is the end of a long day.
What was your concern about the questions that weren't being asked and why they weren't being asked?
Okay, so I've come out of community care. I was working in district nursing, and I was working with people with dementia in the community, and one of the biggest things they kept saying to me was that they didn't feel like their doctor was hearing what they had to say, and they were getting really frustrated that basically they just weren't being listened to. So I moved into primary care and did some research around what the situation was, and found out that people in general practice simply do not talk to people about how their memory is or what's happening with them at home.
Okay, so there are a lot of people in general practice, and number one are the general practitioners. Why is this a nurse project and not a GP project?
Okay, well, because we have the relationship with the patient. For the last, I think, 20 odd years, we've been the most trusted profession. We spend an awful lot of time with people, particularly older people, doing care planning and finding out about their lives, and over time we get to hear about their families and the things they're interested in, and so you start to notice when things start dropping off. Suddenly they're not attending bowls twice a week, or they're no longer going and doing the knitting for the preemie babies, because heaps of people do little beanies, and you start asking, well, why is this happening? And so I think it's the practice nurse, because we have the relationship with the person, we have the time, and generally I think it's the type of people we are. We're interested in people living well.
And yet you said there's lots to learn about talking about dementia and cognitive function, etc. And that, in fact, you gave a few pointers. One included leaving your bias at the door, and you gave some really interesting examples about foot incontinence, a whole range of things. Can you just run through a few of those things?
Well, I think one of the things we do is we do make assumptions. And so someone comes into us for a care plan and we get very focused on the disease, and it might be that they've got diabetes or something, and then they're not managing it well, and so we're thinking, they need some more education. They're, maybe they're not compliant, so therefore they're bad or whatever. And then you start probing a bit deeper, and it might be that they can't use the machine because they've forgotten how to. So we've got to start thinking a little bit around the box. So start asking questions about, why the gas supply for safety, and giving them a microwave that they've never used before, and they can't learn new skills. And so they need an occupational therapist to come in and help them, rather than a dietitian to teach them about diet. So it's just looking things from a different lens and hearing what people have to say and why they're having problems.
And what would you say is that you're doing differently now as a result?
I think what I'm hoping is that my biggest thing is promoting people to have the conversation about cognition. And because it takes courage, it's a really difficult conversation, and people are worried that they're going to upset people. I never use the dementia word. It's really just saying to people, look, I've noticed you're finding this more difficult. Can you tell me a little bit more about it? So really the change I want to see happen is not so much having a clinic or a service, it's about changing the way we have a conversation with people and listening through thinking maybe something else is going on that's not so obvious.
So what has been the response of the others in general practice and of patients to the idea of a nurse clinic?
I think it's been challenging in our practice, and I think part of it is the fact it is dementia. I mean, we know internationally and through Australia that it's not managed well in general practice, and so those challenges aren't going to just disappear. There's multiple layers of it, and so I think one of the things that I've tried to work with the GPs is that if they ask this question about cognition and they think there's a problem, that there's somewhere to go with it. They can then refer to the practice nurse to do a care plan that is going to be what I call a cognitively aware care plan, so that it is talked about, it is thought about. And that's the biggest thing that GPs were like, one of the biggest barriers was that, well, if we ask, what are we going to do? We can't go anywhere with it. And so my idea is I provide resources so people can go somewhere with it.
Do you find that surprises people, that GPs would think that? Because isn't that actually general practice care?
Well, we know that 50% of people in the community who have dementia are undiagnosed, which is a lot of people. And it's simply because it is known, research says that we do not ask people about their cognition, or people do not volunteer that information. And so I found it surprising, but it's a common theme, and there's no guidelines or education for practice nurses around dementia care.
None internationally.
None internationally at all, and so this is all quite new. And I think one of the impacts I've had, which has been fabulous, is not so much just within my GP service, but it's been picked up and people are interested in South Australia, in Hobart, wanting to know what we've learnt and sort of what model of care we've come up with, what resource, and just this support that it's recognised we do have to start talking about dementia in primary care, and we've got some clues and ideas for people to play with to try and do that.
And can you measure your impact in terms of patient care?
It's difficult to measure. That's something that needs further work. There are some quality of life measures because, of course, as a nurse or health practitioner, we always go in with the idea we want to make people's lives better, their quality of life. But they're very difficult to use in dementia because people are progressing down cognitively, which interestingly usually means they start rating their quality of life higher. And so they're difficult measures, and they're difficult around the support person as well. But I'm sure there will be some, but it's something I think that needs some more research around what are good measures.
And how do you as a team measure your effectiveness?
I think it's more that anecdotal evidence that I know from seeing people, and I know that in the community as well when I worked with people with dementia and their carers, is that people respond really warmly to you. I always remember this lovely lady, one of the first people I worked with, and I think it was about 6 months or some down the track, she just looked at me and said, I have absolutely no idea why you come here, but I feel good. And I just thought, well, that's a win. You know, she felt better because I was there, and she didn't know why I was there. Couldn't remember me from the multitude of previous visits. And I think, you know, I've had some carers say how much easier life is at home because they're not fighting anymore. They're not trying to say, oh, why don't you do this? I've told you this 1,000 times. Because we said, look, they've started to get an understanding that they can't change the way that person's brain is working now. And so there's ways to get around it, or ways to go around, you know, do things differently.
What's an example? What would be a tip that you would give?
One that immediately comes to mind is explaining, like, often people will shadow when they've got dementia. They're anxious. They'll be standing always beside someone. It drives people crazy because they're following them everywhere, saying, oh, what are we supposed to do today? Where are we going today? And one of the things is explaining maybe to the carer that it's because the person's not trying to annoy you, and most probably doesn't actually want to know where they're going, but they're anxious and worried. And so it's more about making them feel safe, and so it might be sitting them down and saying, here, have a cup of tea and all that. And then the other part of it is don't tell them if there's a doctor's appointment in a week's time, because they're going to forget it, but there's going to be a seed of it winding them up and making them anxious and worried because they're thinking, there's something happening, but I don't know what it is. And so I just say to people, either write it on a big calendar if they're at that stage that they can remind themselves, or if they're not, then just tell them at the last minute that, oh, look, we're going off to the doctors now. Not the last minute, but we're going off to the doctors now. It's time to get ready. Let's go. And just reassure them you're safe, you're going to be with them. And often you can pull down that shadowing and that anxiety. So that would be one thing.
And now, the last questions, because you've got to go up and frock up for this the costume ball. What do you need to do this work better? From government, from the health system, from practice?
Autonomy in some respects, being able to follow your lead, to have more time to decide the way you're going to plan your day and you're going to do your work.
So does that mean dedicated funding?
I think what I'm talking about is just better care for the whole person, and the fact is that they happen to have dementia. So I just think it's really that, maybe, the input of funding into us having time to spend with someone and unravel some of the issues that are, limiting their life's quality. So I don't know, I suppose it's time and money, isn't it?
Always, sadly. Thank you so very much for talking at the end of the day.